In this part of the test, you'll hear a healthcare professional, Sarah Chen, physiotherapist, consulting with a patient, Mr. Collins, regarding his progress following a total knee replacement. Now you have 30 seconds to look at the notes.
Good morning. Please come in and have a seat. How are you doing today?
Good morning, thanks. I'm doing all right, all things considered. A bit better than last time, I think.
That's good to hear. It's been 2 weeks since our last session, hasn't it? How have things been managing at home? Any major changes or concerns since we last met?
Yes, 2 weeks already. Time flies, even when you're taking it slow. Well, overall, I'm feeling stronger, definitely. I can get around the house much easier without feeling completely drained, but I have a couple of things I wanted to mention.
Please, go ahead. That's what we're here for.
Right, so the first thing is the stiffness. Every morning, when I first wake up, my knee feels incredibly stiff. It takes a good 15-20 minutes of gentle movement before it starts to loosen up. It's not painful, not really, but it's quite restrictive.
Nodding, making a note. Morning stiffness, okay. And how long does that stiffness last once you've started moving? Does it come and go throughout the day, or is it mostly just in the mornings?
Mostly in the mornings. Once I'm up and about, it generally feels much better. Sometimes if I sit for a long time, like watching TV for an hour or so, it'll get a bit stiff again when I stand up, but not as bad as in the morning.
That's a very common experience at this stage of recovery. It's often related to the joint fluid settling overnight and the tissues themselves still healing and adapting. What's the other thing you wanted to mention?
The other thing is a bit of swelling. I notice it mostly in the evenings, especially if I've been a bit more active during the day. For example, yesterday, I walked around the local park for about 20 minutes, much further than I've been doing, and by the time I sat down for dinner, my knee felt a bit puffy. It's not huge, but it's definitely there.
Writing another note, mild swelling after increased activity. And how does that swelling feel? Is it warm to the touch? Is it painful when you press on it?
It's not particularly warm, no, and it's not really painful to touch, just feels a bit tight and full. It usually goes down overnight if I elevate my leg.
Okay, thank you for sharing that. Both the morning stiffness and the mild swelling after activity are very typical things we see 6 weeks post total knee replacement. It sounds like you're paying close attention to your body, which is excellent. Now, let's go through some of my assessment questions, if that's all right.
Yes, absolutely.
Great. First, let's talk about pain. On a scale of 0 to 10, where 0 is no pain and 10 is the worst pain imaginable, what would you say your average pain level has been over the past 2 weeks? And what about your worst pain?
My average pain, I'd say it's usually a 2 or 3, just a dull ache sometimes. The worst pain, maybe a 4, and that's usually after I've pushed it a bit too much, like with that walk in the park. It's nowhere near the pain I had before the surgery, thank goodness.
That's fantastic progress. A 2 to 3 average is really good at this stage of recovery. And how often are you needing to take pain medication, if at all?
I've mostly stopped the stronger painkillers. I just take paracetamol occasionally, maybe once a day, or if I know I'm going to be a bit more active. Sometimes I don't take anything at all.
Excellent. That shows your pain is well controlled and decreasing. Next, let's talk about your activity tolerance. You mentioned a 20-minute walk. How does that feel compared to, say, a week or 2 ago? What kind of activities are you able to do now that you couldn't before?
The 20-minute walk felt like a big accomplishment. A couple of weeks ago, 10 minutes felt like a marathon. I can now walk around the house without the crutch, which is a huge relief. I still use it if I'm going outside or if I feel a bit unsteady. I can manage stairs much better now, one step at a time, leading with my good leg going up and my operated leg going down, just like you showed me. I can also stand for longer periods while doing light chores like washing dishes.
That's wonderful progress. Being able to ditch the crutch indoors is a significant milestone. It shows your strength and balance are improving. How about your home exercise program? Have you been able to adhere to the exercises we discussed? How often are you doing them, and for how long?
Yes, I've been very diligent with them. I do them twice a day, usually morning and evening for about 20-25 minutes each session. The quad sets, knee bends, heel slides, leg raises. I try to do them exactly as you demonstrated. I've even added a couple of more repetitions to some of them, as you suggested I could, if they felt easy.
That's exactly what we want to hear. Your dedication to your exercises is really paying off. The more consistent you are, the better and faster your recovery will be. Now let's talk about those concerns you raised earlier and how we can address them.
Okay.
Regarding the morning stiffness and the mild swelling after walking, as I mentioned, these are very common. The stiffness will gradually reduce as your knee continues to heal and your muscles get stronger and more flexible. For the swelling, it's a sign that you're pushing your activity just a little bit, which is actually good as long as it's not accompanied by an increase in pain. It means your body is responding to the demands you're placing on it.
So it's not a bad sign then? I was a bit worried I was overdoing it.
Not necessarily a bad sign at all, as long as it's mild and resolves with rest and elevation. It means you're finding your limits, which is part of the process. We want to gradually increase your activity, but smartly. Let's talk about increasing your walking time. You mentioned you walked for 20 minutes yesterday. How did that feel during the walk itself?
It felt good, actually. I was enjoying the fresh air. It was only afterwards that the swelling came on.
Perfect. So here's how we can safely increase your walking time. Instead of thinking about one long walk, try to break it up. For example, if you want to aim for 30 minutes of walking in a day, you could do 2 15-minute walks or even 3 10-minute walks spread out throughout the day. This allows your knee to rest and recover in between, reducing the chance of excessive swelling.
Oh, that's a good idea. I hadn't thought of it splitting it up.
Exactly. Listen to your body. If you feel a mild ache starting, that's your cue to slow down or take a short rest. The goal is to gradually increase the total duration and frequency, not necessarily the intensity or speed right now. Aim to increase your walking duration by no more than 10 to 15% each week. So if 20 minutes felt manageable, maybe next week you aim for 22 to 23 minutes as your longest single walk, or increase your total daily walking time to 40 to 45 minutes spread out.
That makes sense. A more gradual approach.
Exactly. Now about the stiffness, especially in the mornings. Regular stretching is going to be key. Are you doing any specific stretches for your knee and the surrounding muscles?
I do the heel slides, which stretch the back of the knee, and the quad sets. I try to do some gentle bending and straightening of my knee before I even get out of bed.
That's a great start with the gentle movements in bed. To specifically target stiffness, I want to emphasize holding your stretches for a bit longer. When you do your heel slides, try to hold that bent position for 20 to 30 seconds. And when you're doing your knee extensions, try to hold your leg straight with a towel under your heel, letting gravity gently pull it down, again for 20 to 30 seconds. We want to encourage the knee to regain its full range of motion.
In this part of the test, you'll hear a healthcare professional consulting with a patient, Mr. Ryan, regarding an acute injury sustained during a sports match. Now you have 30 seconds to look at the notes.
Good morning. Please come in and have a seat. How are you feeling today?
Morning. Honestly, not great. My knee is really bothering me.
I understand. I've seen your referral notes regarding the incident during your last match. Could you please tell me in your own words exactly what happened?
It was late in the second half. A tackle came in from the side pretty hard. My foot was planted and my body twisted awkwardly over my leg. I felt an immediate sharp pop, almost like something snapped, and then this searing pain. I went down instantly.
I see. And what happened immediately after that?
The team physio came on and they helped me off the pitch. It swelled up pretty quickly and I couldn't put any weight on it. I've been using crutches since then.
Thank you for that detailed account. Let's delve a bit deeper. On a scale of 1 to 10, with 10 being the worst pain imaginable, what would you rate your current pain level?
Right now, probably a 6 or 7, especially if I try to move it or put any pressure on it. When it first happened, it was easily a 9.
And have you noticed any changes in the knee since the incident, besides the swelling? Any clicking, locking, or a feeling that your knee might give way?
Yes, definitely. It feels unstable, almost like it wants to buckle sometimes. And I tried to bend it a little this morning, and it felt like it caught, almost locked up for a second before I could move it again.
That's important information. Now, have you had any previous knee injuries or surgeries on either knee?
No, thankfully. I've been pretty lucky throughout my career, just the usual bumps and bruises, but nothing serious on my knees. This is my first major injury.
All right, let's talk about your functional limitations. Besides walking, have you tried bending your knee, climbing stairs, or anything else that you normally do without thinking?
Bending is incredibly painful and limited. Climbing stairs is impossible without putting all my weight on the good leg. Even just shifting in bed is difficult. I haven't been able to train or even jog, obviously. My whole life revolves around my physical fitness.
I completely understand your concerns. As a professional athlete, your body is your livelihood, and an injury like this is naturally very worrying. Based on what you've described, the mechanism of injury, the immediate pop, rapid swelling, instability, and the locking sensation, we need to consider several possibilities, including ligament damage, particularly an ACL tear, and a meniscal injury. It could also involve other soft tissue strains, but those are the primary concerns given your symptoms.
An ACL tear? How long would that keep me out? I have the national qualifiers coming up in a few months, and then the European Championship. This can't happen now.
I hear your concerns about your career and the upcoming tournaments. It's completely natural to feel that way. However, at this stage, it's crucial that we get a precise diagnosis. The best way to do that is through an MRI scan. It will give us a detailed picture of the internal structures of your knee, the ligaments, cartilage, and menisci, and help us understand the full extent of the damage.
So an MRI is the next step. When can I get one?
I'll arrange for an urgent MRI for you, hopefully within the next day or two. In the meantime, it's vital that you manage the acute symptoms correctly. I recommend following the RICE protocol. Rest your knee as much as possible, ice it regularly for 15 to 20 minutes at a time, apply compression with a bandage to help with swelling, and elevate your leg above your heart whenever you're resting.
And should I keep using the crutches?
Absolutely. Do not put full weight on that leg. Continue using your crutches to offload the knee entirely. Avoid any strenuous activity, twisting, or sudden movements. We need to protect the joint from further damage. Once we have the MRI results, we can discuss a definitive treatment plan, which might involve surgery or a comprehensive rehabilitation program.
What about physiotherapy?
Physiotherapy will be a critical component of your recovery, regardless of the final diagnosis. However, in this initial acute phase, our focus is on reducing pain and swelling. Once the acute information subsides and we have a clear diagnosis, we can start a tailored physiotherapy program under professional guidance. This will help restore range of motion, strength, and stability.
So there's a chance I can get back to playing at my level?
With proper management and a dedicated, gradual rehabilitation program, returning to professional football is certainly possible. Many athletes recover fully from these types of injuries. However, it's a process that requires patience and adherence to medical advice. Rushing your recovery or returning to play before your knee is fully healed and stable could unfortunately lead to re-injury or long-term complications. Your long-term knee health and career are our top priorities. We will work closely with you and your team's medical staff throughout this journey.
Thank you. That makes a lot of sense. I need to know what I'm facing.
And we will get you that clarity. I'll send the MRI request through now and have my assistant call you with the appointment details. Please don't hesitate to contact us if your pain worsens or if you have any other concerns before your next appointment.
I will. Thank you.
All right, Mrs. Johnson, before you head home, let's go through your discharge plan together. Continue your low-salt diet and take your medications as prescribed. Now, about the wound, it's showing good signs of healing, but it still needs regular care. Try to keep the area clean, dry, and covered, and remember that the dressing should be replaced once every day. Doing it daily helps keep the wound free from moisture and reduces the risk of infection. When you change it, take a brief look to make sure everything appears normal. If you happen to notice any unusual discharge, particularly if it's yellowish or has an unpleasant smell, that could suggest infection, and you should let us know. The district nurse will assist with the changes for the first few days so you can see the correct technique, but after that, you'll continue managing it on your own. If the area becomes warmer than usual, turns red, or the pain suddenly gets worse, contact the clinic straight away. Staying consistent with daily care is the best way to make sure your recovery continues smoothly.
Mr. Davies, I'd like to take a moment to discuss your new blood pressure medication, lisinopril. There are a few side effects you should be aware of. The most frequently reported is a dry, lingering cough. It's generally mild and doesn't require treatment, but if it becomes troublesome or interferes with your daily activities, please contact your GP for advice. Occasionally, some patients experience facial or lip swelling, which is a rare but serious reaction. Should you notice any swelling of the face, tongue, or throat, stop taking the medication immediately and seek urgent medical attention. You may also experience a slight feeling of lightheadedness or dizziness when you first start the medicine. That usually settles within the first week as your body adjusts. To reduce the risk of dizziness, it's best to stand up slowly from sitting or lying positions. We need to update the patient's allergy information to ensure it accurately reflects her medical history. At present, her chart incorrectly lists penicillin as the allergen, but that was identified as an error by one of the nurses during last month's review. The true allergy is to sulfa-containing medications, specifically sulfamethoxazole. According to the previous documentation, her reaction was anaphylaxis, which is a severe and potentially life-threatening response. Because of the seriousness of this reaction, it's essential that all records, both electronic and paper-based, be promptly corrected to reflect this information. Please also verify that her wristband and allergy alert labels are updated to indicate a sulfa drug allergy. This will help prevent any inadvertent administration of contraindicated medications and ensure the patient's safety during future treatments or admissions. Good morning, everyone. I'd like to take a moment to remind you about the updated protocol for patient transfers. While our primary goal remains to ensure patient comfort and safety during the transfer process, we now need to pay particular attention to the accuracy and completeness of handover documentation. We recently identified several instances where medication charts were either incomplete or contained missing signatures, which can lead to confusion and potential risks in continuity of care. From this point forward, please make sure that all sections of the transfer documentation, including medication records, vital observations, and nursing notes, are fully completed before the patient leaves the ward. Also, remember that the new security clearance step is now mandatory. It may take slightly longer, but it's essential for maintaining patient confidentiality and ensuring that only authorized personnel are involved in the handover process. Let's keep the emphasis on clear communication, accountability, and thorough record keeping so that each transfer runs smoothly and safely.
Mr. Green, we've gone through your X-ray results, and I am pleased to confirm that there's no sign of a fracture, which is excellent news. What you're experiencing is pain caused by a considerable strain of the shoulder tendons, not a bone injury. We'll begin treatment right away to help manage the pain and promote healing. It's important that you start the prescribed home exercise routine, as these exercises will gradually restore strength and flexibility to your shoulder. However, to address the acute discomfort, we'll be using ultrasound therapy, which should provide the most effective short-term pain relief by reducing inflammation and improving circulation in the affected area. In addition, we'll apply supportive taping to stabilize the shoulder joint and prevent overstrain, though that's more of an adjunct measure. The ultrasound therapy and exercises remain the key components of your recovery plan.
Hello, Dr. Lee. Just calling with the results for your 45-year-old female patient. The CT scan confirmed our suspicion of an obstructing renal calculus. It's quite large, 12 millimeters, and is currently lodged in the proximal ureter, causing the hydronephrosis. I note you mentioned trying conservative management first. Given the size and location, that is now unlikely to be successful. I'd advise proceeding directly to ureteroscopy to remove the stone, as a simple lithotripsy won't be sufficient for a stone of this dimension.
You will hear an excerpt from a medical lecture given by a cardiologist on the challenges of diagnosing myocardial infarction, MI, in specific patient populations. You now have 90 seconds to look at the questions.
Good morning. Today's focus is on what we call the atypical presentation of myocardial infarction, a topic vital for all clinicians. We know the textbook presentation: a middle-aged man clutching his chest, reporting central crushing chest pain radiating to the left arm. But in reality, particularly among women and the elderly, this clear picture is often absent. The primary challenge we face isn't just symptom variability, but the healthcare system's inherent bias towards that classical pattern, leading to underdiagnosis. When we look at women, chest pain remains the most common symptom, but critically, it's less likely to be described with that characteristic crushing severity. Instead, it often manifests as discomfort or a tightness localized in the back, neck, or jaw. A crucial distinction is that women frequently report shortness of breath, fatigue, or generalized weakness before or instead of chest pain. Furthermore, symptoms like nausea and vomiting are disproportionately common in women presenting with MI, and these are unfortunately often dismissed as being due to gastrointestinal upset, leading to dangerous delays in diagnosis. The challenge is amplified when we turn to the elderly. Patients over 75 are less likely to experience any chest pain. Their symptoms tend to be far more subtle and nonspecific. Often the presenting complaint is simply extreme debilitating fatigue or profound weakness. We see this presentation frequently substituted for chest pain. In many cases, the MI presents as an acute, unexplained deterioration in their baseline functional status, perhaps a sudden inability to perform daily tasks. Because these symptoms lack the clarity of typical chest pain, these patients are often diagnosed with non-cardiac conditions or simply attributed to old age. This ambiguity directly contributes to the fact that they often delay seeking medical attention until the infarction is well established. This brings us to the term silent MI. It's a misleading term. It doesn't mean the MI occurs without symptoms. Rather, the symptoms are so subtle and nonspecific, they are easily missed or misinterpreted. The symptoms are often present but not recognized as cardiac in origin. The key takeaway is this: for high-risk patients, those with diabetes, advanced age, or female gender, we must maintain a high index of suspicion. We cannot rely on the classical presentation. The moment a high-risk patient reports any sudden unexplained change in their baseline function or unusual symptoms, we must assume a cardiac event until proven otherwise.
Good afternoon, everyone. In primary care practice, one of the most persistent and complex challenges we face is the management of chronic non-cancer pain, or CNCP. That is, pain lasting beyond the expected period of healing, typically for more than 3 months. This kind of pain doesn't simply linger, it reshapes a patient's life. For years, our approach was rather linear. Identify the source of pain and eliminate it, usually through pharmacological intervention. We believe that if we targeted the physical structure, the joint, the nerve, the muscle, we could resolve the problem. However, that strategy, while logical in theory, has fundamentally failed a large proportion of patients. The main obstacle is not necessarily finding the perfect medication. Rather, it is recognizing that our therapeutic lens itself must evolve. We must move beyond a narrow biomedical framework, one that focuses purely on anatomy and pathology, toward what we now call the biopsychosocial model of pain. This model acknowledges that biological, psychological, and social factors intertwine intricately to shape how a person experiences and copes with chronic pain. This shift in understanding is not merely semantic. It represents a scientific and clinical paradigm change. Chronic pain is no longer regarded as a lingering symptom of past injury, but rather as a disease entity in its own right. Neurophysiological research has shown that in many chronic pain states, there are maladaptive changes within the central nervous system, particularly in how the brain and spinal cord process pain signals. In other words, the body's alarm system becomes hypersensitive and continues to sound even when there is no ongoing tissue damage. This faulty alarm system is what sustains chronic pain, independent of the original injury. When we design a comprehensive management plan for CNCP, therefore, our first step is not to ask, "How bad is your pain today?" or to chase fluctuating pain scores. The more effective starting point is to establish realistic functional goals. We need to reframe the conversation away from complete pain elimination and toward functional restoration. So instead of asking, "How can we make the pain go away?" we might ask, "What are you hoping to be able to do again?" That could mean walking the dog for 30 minutes, playing with grandchildren, or returning to a beloved hobby. These function-oriented goals are measurable, motivational, and far more relevant to quality of life than abstract numeric ratings. Equally vital to this model is the emphasis on non-pharmacological strategies. Structured physical therapy is certainly foundational. It rebuilds strength, improves mobility, and helps correct maladaptive movement patterns. Yet evidence consistently shows that the greatest long-term improvements often come from empowering patients with self-management toolkits. These include education about pacing, the art of balancing activity and rest, sleep hygiene, since poor sleep amplifies pain perception, and cognitive restructuring techniques that help patients reinterpret pain signals and reduce fear-based avoidance behaviors. When patients learn that they can exert influence over their condition, even if they cannot eliminate it, they regain agency, and that empowerment itself is therapeutic. Turning to pharmacological treatment, we must tread carefully. One of the major pitfalls in CNCP management is the early or aggressive use of opioids. Initially, opioids may provide short-term relief, but the evidence overwhelmingly demonstrates that prolonged or high-dose use carries significant risk. Beyond dependence and tolerance is the paradoxical condition known as opioid-induced hyperalgesia, where, over time, the medication itself heightens pain sensitivity. This is one of the most underappreciated reasons for treatment failure and one of the strongest arguments for judicious, time-limited, and closely monitored use. Finally, let's consider your ongoing role as primary care physicians. You are not merely prescribers or gatekeepers to secondary care. You are, in many ways, the central coordinators of the patient's pain journey. Your task is to act as a consistent presence, a facilitator and coach, guiding the patient through the inevitable ups and downs of living with chronic pain. You help them stay anchored to functional goals, reinforce the principles of self-management, and provide continuity when their motivation falters. In essence, you become the bridge between science and lived experience, ensuring the pain management remains compassionate, evidence-based, and sustainable.